I think this is something important because we need to follow the patient, particularly due to the side effects. Even if it's a classical side effect, well-known side effect, particularly with osimertinib, it's mainly grade 1, grade 2 side effect in terms of digestive, in terms of skin toxicity, but we can anticipate and manage the side effect. And we need to anticipate also the side effect of platinum-based chemotherapy, mainly hematological toxicity and also the GI toxicity, and mainly within the first 3 months, because this is this part in which the patient receives the 4th cycle of platinum-based chemotherapy. After you stop platinum-based chemotherapy, and generally the toxicity decreases over time. So that's why in this induction period, the nurse are really important to try to better manage, anticipate the side effect, and to prevent the development of side effect. So you can maintain the dose intensity of the treatment. And I think this is something important to try to cure much more patients. The initial treatment, the induction period, is something really important in this population. So the nurse, clearly, they can anticipate all these side effects to try to not discontinue the treatment or try to avoid the dose reduction of the treatment. But skin, and particularly the digestive side effect, you can better manage if you have a nurse to help the patient due to the secondary adverse event, grade 1 and grade 2. I think nowadays we imply more and more this clinical nurse during the clinical trial. In parallel, when they see the medical oncologist nowadays, we try to make also specific consultations with the nurse, and the nurse can also follow the patient sometimes just by the phone if there is some specific adverse between the different consultations. And again, the fact to anticipate and to have a better follow-up of the patient made the things better for the patient in terms of quality of life, and to maintain the intensity of the treatment. And again, to try to anticipate all the side effects. Don't try to wait the next consultation with a medical oncologist, because sometimes it's too late. And sometimes the patient, they discontinue the treatment before to come to see you in consultation. So if you can act and have a specific follow-up with a nurse included in the clinical trial, you will anticipate and probably you might imagine potentially to improve the benefit of the treatment and finally improve the probability to have positive result. So I think this is something we are doing more and more, and particularly if patients do not need to come in hospitalization for the infusion for the treatment. If it's per month treatment, patient can be followed easily by the nurse in the clinical trial in parallel with a medical oncologist. I would say it's important to share all this type of data. So we need to improve our knowledge. And the next thing is probably how can we better select the patient? We have specific biomarker, and I think this is a medical question for the oncologist and even for the patient. And so that's why nowadays we try to have a specific treatment, patient per patient, depending on the genotype alteration on the tissue, but also on the liquid. And this is something we need to share with the patient to improve the overall survival in our patient.